Hello, everyone. Good afternoon. How are you doing today? Welcome to second tutorial session. And this week we are going to be looking at cardiovascular system. We are going to do some questions to review some of the topics we were able to discuss in the group during the week and try to reinforce the concept. Today's session will take a different format. We are going to, Today's session will take a different format. So we're going to I'm going to be displaying questions and give you guys about 2 minutes to attempt the question and pick an answer from the poll. And then we'll discuss the question together. So the idea is to show you maybe what you would have done differently or compare your own approach to what we're going to discuss together and see if there are areas that need improvement. Okay. And then, but before we get started with the question, I will talk a little bit about how to review your blocks, right? So a lot of you have concerns about how to review blocks after doing it, how to review blocks faster, how to be more efficient with reviewing blocks, etc. So I'll give a brief tip, 5-minute tip on that, and then we'll go into the questions. And thankfully today we have 2 hours instead of 1 hour, so there will be more time to do more things. What I've found out about reviewing questions, number one is, or one thing to consider, the first thing is going to be, if you can time your blocks, right? If you can time your blocks, why not time your review as well? Okay, so if I time my blocks, why can't I time my review? So there should be a sense of urgency, right, when you're reviewing as well. And what most people do is they time their blocks, but they take as long as it takes to review a block, which shouldn't be so. So that will decrease the total number of questions you're able to review per day. And remember that repetition is more helpful in your exam when you're preparing for your exam than spending too long on one concept. It's better to see it over and over again multiple times and stress your brain to remember and things like that than to spend so long, right, on one concept. So that's going to be very important. And then, so I usually encourage students to time their review. So once you're done with your timed blocks, when you want to review the block, set a timer as well. You can set a timer for 2 hours, right? You can set it for 2 hours, 30 minutes, but you should set a timer, time your review. So that's number one. Number two, the best way to make your review efficient is to understand the objective of the review. I am not reviewing my blocks because I want to waste time reviewing or reading things I already know. My focus and emphasis should be on things that I don't know or clearly understand. That is the objective of a review. I want to master those things that I don't know clearly. I want to make things that I don't know clearly or I don't know before. I want to know them better or make them clearer. So that's important. The reason that's important is because I can prioritize my review, right? So the first thing is time your review. The second thing is prioritize your review. So if I want to review a 40-question block, I will start by reviewing all the wrong questions first. That's what I'm going to do. I'm not going to be going in order. I don't have to go 1, 2, 3, 4, 5, 6 in order. I can start first with all the wrong questions. So if I get question 1 wrong, I'll review question 1. If the next question I get wrong is a 5, I will jump to question 5. If the next question I got wrong is question 8, I will jump to question 8, right? So prioritize your review the wrong questions first. And after you review the questions you got wrong, and those are the questions that will take the most of your time, right? Because you got them wrong, you want to figure out why you got it wrong. You want to make sure your thinking aligns with the examiners, right? Thinking and explanation. So I want to do that. And then after I review the ones I got wrong, I will review the questions I got right, but I flagged. So those ones, you got them right, but you flagged them, meaning there's something you're not clear about. You're unsure about something, so I want to quickly clarify that. Then you now go through the question. Thirdly, you now go through the questions that you got right. The purpose of going through questions you got right is not to go and reread what you already know. If I'm confident about a question, I got it right, I know I got it right, I know why the options are wrong, the other options are wrong, I'm not going to be reading the review all over again. That's a waste of time. You're not going to learn anything new, right? What you want to make sure there is just to make sure that you're thinking. The reason for picking the right answer is the same reason the examiner has. So I'll quickly glance through the explanation and make sure the examiner's reason aligns with mine, and I will move on. So this kind of question should not take you more than few seconds to go through, right? The ones that you got right. And that's how you can be more efficient. So when I'm reviewing, I should time my review. So that way I'm not spending too much time unnecessarily, right? I should time my review. Secondly, I want to prioritize my review, starting with the wrong questions first in that block. The ones I got wrong, I'll start with them first. Those ones that take more time, those ones probably contain concepts that I really don't understand, I'm not clear with. So I want to prioritize them, do them early in my review. Then secondly, I'll now go through the questions I got right, but I flagged to clarify my uncertainty. And then thirdly, I can quickly brush through or even skip the questions that I got correctly and I'm confident about. All right. So those are two tips that can help you really make your review more efficient so that you can go from reviewing 40 questions a day to probably reviewing 80 or more, right? If you're able to time it and also prioritize, right, your review. All right. So that is the tip for today. I hope it is helpful in your applications. So let us jump into questions. So I'm going to be sharing my screen now, and please let me know if you cannot see my screen, but I'll assume by your silence that you can, right? See my screen. So we're going to start with this first question. Let me see if we can make this a little bit, it's too small. Let's see if we can put everything on the screen, but that would be too small. So I'm going to be displaying a poll, right? And you can minimize the poll, you can make it smaller, put it aside, and I will show the question. So the objective will be, we'll go through the question, everybody go through the question in like 2 minutes and pick an answer, right, in the poll, and the poll will close in 2 minutes, and then we're gonna discuss, right, the question together, so that way you can compare your approach, right, with ours, okay? So this is the first question. I've already shared the poll, and you can feel free to pick an answer in the poll. After going through the question, I will show the rest of the question. So this is the question and the options. I will show you the rest at the top and the picture as well. Yeah, so in your exam, you have 90 seconds per question, but for this review, I'm giving 120 seconds, okay? Poll is almost closing, so pick an answer. Closing the poll in 5, 4, 3, 2, and 1, okay? All right, so From the poll, the most popular result is answer is option C, genetically mediated abnormality in sarcomeres, and someone picked D, which is an infiltrative disease due to deposition of amyloid fibers, right? Okay. So from the question, this is asking which of the following is the most likely cause of this woman's condition, right? Cause of the woman's condition. So I have to figure out what the patient's condition is in the vignette and then figure out what the cause is. And we're giving options: genetically mediated abnormality in cell junctions, abnormality in ion channels, abnormality in sarcomeres, deposition of amyloid fibrils, and we have deposition of granulomas, right? So we need a clue to the woman's condition. And here we're given a 45-year-old woman collapses and dies despite proper resuscitation. One thing is when you get vignettes that have pictures, right? When you get vignettes that have pictures, images, etc., I think the best approach would be to ignore the image initially and read the vignette. The reason is because you find out that most of the time you don't need the image. Some cases you don't need the image or the graph or whatever else, right, to actually answer the question. By just reading the vignette, you're good to go. But sometimes you might need the image, but at least you would have something in mind, right? I would have a differential in mind. I'll have some ideas in mind from the vignette before I look at the image. However, there are those that can still pick an answer from the image alone. If the image looks familiar, but still sometimes can be a distractor, right? And you don't really need it to pick an answer. So I'll still encourage you to read the vignette first before you look at the image. Have something in mind from the vignette before you look at the image, because some images might be misleading or be distractors and they may be unnecessary, right, to pick an answer. So this is a 45-year-old woman that collapses and dies despite appropriate resuscitation efforts, right? So like sudden cardiac death. Prior to the episode, she reported substernal chest pressure brought on by exertion, as well as episodes of palpitations and lightheadedness, right? So for the purpose of USMLE examination, when a patient, so this is a vignette about sudden cardiac death. When a patient has or experiences sudden cardiac death, there are some top differentials that should be on our mind. Who can tell us? If you encounter sudden cardiac death vignettes in your exam, USMLE exam, what are the top differentials that you'll be thinking about? You can type it in the chat. Top differentials for sudden cardiac death, things that you must think about. Very common in the exam, commonly tested. Sudden cardiac death. All right. Opa mentioned Ocom. Anyone else? Anything. Sudden cardiac death differentials. Ocom, yes. What else? Sudden cardiac death differentials on USMLE or NBME. Cardiomyopathy. It's possible cardiomyopathy. It is possible. But even before I think of cardiomyopathy, there's something else. Actually, you're thinking of a patient that's otherwise healthy. If somebody has cardiomyopathy, they would likely have symptoms before. Outcome is cardiomyopathy, I agree. MI patient is gonna be, they will have like risk factors before, they'll have other things that'll tell you they've had MI. But I'm talking about a patient that is otherwise LD, young, like this patient, 45 years old. She's otherwise LD. They didn't tell us she has any other risk factors in the past, nothing else, and she just suddenly died. Another thing that we think about is what prolonged QT interval, right? So congenital, so arrhythmias should be on your mind as well. Prolonged QT interval. Okay, so sudden cardiac death in otherwise LD patient, outcome prolonged QT interval, right, which can lead to arrhythmia to start, right? Those two are commonly tested, right, for this purpose. Okay, so those are the two things that at least should be on your mind, right, at the top. But of course, there are other causes which you can see in people that are already symptomatic or have other risk factors. But if it's otherwise healthy patients, right, you're likely infiltrative heart disease, they would have symptoms in the past. Patient will not be healthy, right? Otherwise, they would have been having symptoms for months before their heart stops. But I'm talking about heart stopping without any warning, in a young patient, no risk factor, nothing, these two, right? will be at the top of my differential, right, for that patient, okay? So in this case, we're giving histology, right? Myocardial histology. So if I'm thinking of these two top differential, which one will I say abnormal myocardium on histology? So what we're giving here, we have this myocardium that are abnormally arranged, right? They look in disarray, disorganized. So this will point to what? Between our two differentials, what do you think this patient likely has based on the histology we're given? Outcome or prolonged QT interval? Outcome or prolonged QT interval. So this patient likely has outcome, right? Yeah, because of the disarray. What will I see on ECG in patient with outcome? Because I can get the same vignette, but the examiner will not give you histology. The examiner will give you ECG. What will you see? We know for prolonged QT interval, we see the prolonged QT interval, right, on ECG. We can calculate that, measure that, or you can see TOSAD, which is the arrhythmia. But for outcome, what will you see on ECG if the examiner is not giving you histology? And the examiner tries to give you ECG for outcome, what will you see to tell you that patient has outcome on ECG? Hypertrophic obstructive cardiomyopathy. So I'll see tall R waves, right? Because in patients with outcome, there's hypertrophy of the myocardium, of the ventricle, the left ventricle. So the R waves will be very tall on the V-leads, V1, V2, V3, V4, V5, V6. They will be very, very tall R waves, which will tell us that what the muscles in the heart are thicker than usual, all right? So that will be the ECG clue, right, for outcome, all right? Excellent. So our first step, which is the patient's condition, we know it's outcome. And then the question is asking us, what is the what is the cause? In outcome, what is the genetic mutation? In hypertrophic, right? It has a yes. Tall R wave, yes. So what is the genetic mutation in outcome? Hypertrophic obstructive cardiomyopathy. What's the genetic mutation? Hypertrophic obstructive cardiomyopathy. Okay, sarcomeres are mutated. What is mutated in the sarcomeres? So in OCOM, the beta myosin, right, is mutated, right? Beta myosin, one of the proteins in sarcomeres, is mutated, all right? So, and that is why the sarcomeres look abnormally arranged, right? Like we have on histology. If you compare histology with normal cardiac histology, you see that this looks disorganized, abnormally formed, etc., right? And so our best answer here for sure is going to be C, a mutation in sarcomere, beta myosin in sarcomeres that makes them look abnormal, right? Abnormally formed. So C should be the best answer. Another question I have here is, you get the same vignette and the question is asking you, what is the most likely cause of death in this patient? No, like what will most likely kill a patient with OCOM? What cardiac complication will likely kill a patient with OCOM? Why do they develop sudden cardiac death? We know they have outcome fine, but what actually kills them? What complication of outcome kills patients with outcome? You can get that in an exam. Arrhythmia, right? Arrhythmia is the most likely cause of death. Okay, arrhythmia. So because of the way the fibers are arranged abnormally, the conduction system too is affected, doesn't work properly. So anytime they suffer cardiac ischemia or hypoxia, right, the arrhythmias can develop, and that's usually the underlying, right, cause of death in these patients. Okay, arrhythmias. All right, any question on this before we move on? Any question on this? Any question on this? Okay. So the next question is this, and I am going to reshare the poll here. And so this is a question and the option, and I'm going to show you the full question, right? Again. So for this one too, we have about 120 seconds to attempt it. Poll will be closing soon. Poll is closing in 5, 4, 3, 2, and 1. Okay. So this might seem like a harder question because a lot of people did not answer it or attempt it. But let's walk through it. For those that attempted it, I see there's option D. 2 persons picked option D, and 1 person picked option A, right? So if the person that picked, one of the people that picked option D, if you don't mind, can you tell us why? You can unmute yourself if you don't mind and tell us why you're going with D. Should be interesting. If one of the persons that picked option D, if you don't mind, if you're not shy, you can unmute yourself and tell us why you're going with D. Okay, Taza, can you tell us why you're going with C? You can unmute and talk to us. What about the person that picked A? Adebola picked A. Can you tell us why you're going with A? Perfect. So let's go through this together. Given these findings, the patient is at greatest risk for which referring complications. So they want us to figure out what complication the patient can develop. So the question is, what is the patient's condition? What does the patient have now? And we have the complications we're giving: kidney injury, myelosuppression related to the bone marrow, kidney stones, pulmonary infarction, and septic, right? Arthritis. So what are the findings the examiner is talking about? The examiner uses this word, these findings, right? These findings. Whenever an examiner uses these or these, the findings are likely mentioned just before, right, the question. So I'll read the second to the last sentence and see if I can figure out my answer without reading the whole thing, right? So the findings that we're giving here says, on microscopic examination, there are several large caliber vessels with needle-shaped cholesterol clefts in their lumens. Several large caliber vessels with needle-shaped cholesterol clefts in their lumen. So there are cholesterol clefts in the lumen of arteries. And look at this picture here. On H&E stain, cholesterol is going to be, lipids will be degraded, so it will appear white on H&E stain, right? So all these here, this is the lumen of the artery here. And you can see this needle-shaped whitish structures. These are the cholesterol clefts, right? That are occluding the lumen, right, of the vessel. Okay. So what will be the consequence of having cholesterol within arteries, right? These are large caliber vessels, right? What will be the consequence of having cholesterol clefts within vessels? This is going to occlude, right, the vessel. If there are cholesterol clefts in the vessel becomes occluded by those molecules, right? The vessel becomes occluded, right? So occlusion, very good. That's predictable. Occlusion. So of the options you have, which option is tied to occlusion of vessel? In the options we have, which option is tied to occlusion of vessels? What will be the complication of occluding vessels in the options? So two things, right? Okay, it could be A, it could be A, and it could be D. Those are the two things that are related to occlusion of vessels. If the pulmonary arteries are occluded, that will be pulmonary infarction. If the renal vessels are occluded, it's lead to kidney injury. So it's either A or D. So what do we need to figure out next? Which vessels are likely occluded in this patient? Which vessels are likely occluded? So, but when it says large vessel, we don't know, is it arteries or veins? Do you get that? Is it arteries or veins that are likely occluded? We need to figure that out. If it's the veins that are occluded, right, it could be pulmonary infarction. Because if I have cholesterol in the venous system, it will end up in the right heart. From the right heart can end up the pulmonary artery, which is like a vein, right? But of course, it carries blood away from the heart, so we call it an artery. So it could be D. But if it is the arterial system where the cholesterol clefts are in the aorta, right? In the aorta, femoral arteries and renal artery can be affected, right? And that will lead to kidney injury. Does that make sense? So we need to figure that out. So what triggered this patient's problem? They did what procedure? They were doing, this is a 72-year-old man, emergency department due to sudden onset severe abdominal pain accompanied by nausea, history of coronary artery disease, recently underwent cardiac. So this patient recently underwent cardiac angiography. Recently. So after cardiac angiography, he now presented with what? With abdominal pain. When they were doing surgery, they saw this, they saw small bowel, it seems a small bowel infarction, most likely that was resected. And then they saw a lot of large caliber vessels, right? That contain cholesterol clefts. When we do coronary and cardiac angiography, rather, we are inserting what? Catheters into the arteries, right? So we enter through the femoral artery, for instance, and then you go back to the iliac arteries and you enter the aortic artery, the aorta rather, and go all the way down to the coronary, right, artery. So in the process of catheterization, process of angiography, right, we can disrupt what? Atherosclerotic plaques in the aorta, and the core of those plaques contain cholesterol. So that can spill cholesterol right into the blood, and the cholesterol will embolize distally to the branches of the aorta, right, which includes what? Renal artery, as well as mesenteric arteries, and that will explain this patient's small intestinal infarction, as well as possible, right, risk of kidney injury. So that is why A will be the best answer in this case, since the cholesterol are likely in the arterial system. Okay, and D is out. Any question on this? You can write your questions down towards the end. We're going to have some time as well to go through questions, okay? So this is the next one. I'm going to stop sharing the poll and share again. Relaunch poll. All right. I've relaunched the poll. So we go through this again. We have 120 seconds. Go through this question and you pick an answer in the poll. Poll is about to end in 5, 4, 3, 2, 1. Okay. So this is an interesting question. And we have interesting results, mixed results. But 2 persons went for option A, 2 persons option C, and we have 1 person choosing option B. Okay, so let me walk through this. You compare my approach, right, with your approach, okay? So my approach here, of course, we're starting with the last question as we have been Doppler ultrasound irrigation of the fistula. So from this question, I know that there's a fistula, right? Examiner is testing us on a fistula, a communication. A fistula is a communication between 2 things. And the Doppler ultrasound is looking at flow, right? In the cardiovascular system. So we'll most likely reveal which of the following flow patterns. So they want us to figure out how blood will flow right through a fistula. The first concept in cardiovascular system, or a question at least, a question I wanted to consider in cardiovascular system is what drives flow of blood? Who can tell us that? That's my first question. What drives blood flow in the body? What drives blood flow in the cardiovascular system? Pressure gradient. Excellent. So if you know that, right? In fact, do I need to read the vignette in this case? I'm not going to waste my time with this question. I'm not going to waste, this is one of the questions this is the type of question you can save time on. So you don't even have to read the vignette because look at the options. The examiner is telling you the chambers where the fistula is located. It is between what? It's between the fistula is between the aortic root and the right ventricle. The fistula is between the aorta and the right ventricle. So by the principle of pressure gradient, what direction will blood flow? From what you understand by the pressure gradient, which cavity has higher pressure between the aorta and the right ventricle? Which cavity has higher pressure and what direction do you expect blood to flow between those two chambers? It has to, right, aorta has higher pressure, good. So the flow will go from the high to low. It's going to go from the left, another way, Oge gave us another way of thinking about it, from the left to the right. That is from the right side of the heart, which includes the aorta, from the left side to the right side. So the aorta is part of the left side of the heart where we have higher pressure, and the right ventricle is on the right side where the pressure is generally lower. Now, the next question is, the examiner now wants us to determine, will the flow be different during systole or diastole, or it will be continuous? What do you think? Is the aortic pressure lower than right ventricle at any point during the cardiac cycle, or it's higher than right ventricle throughout the cardiac cycle? What do you think? Is the aortic pressure higher than the right ventricular pressure throughout the cardiac cycle, or at some point aortic pressure is lower than the right ventricular pressure? I disagree. The aortic pressure is higher than right ventricular pressure throughout. What is the lowest pressure in the aorta in a healthy patient? It's 80 millimeter mercury, right? The diastolic pressure. What is the highest pressure in the right ventricle? It is the pressure in the right, the highest pressure in the right ventricle will be the pressure in the pulmonary artery, which is about what, maybe 30, 25, 30. Do you remember that? The highest pressure in the right ventricle will be like 35, 25, 30 millimeter mercury, right? The lowest pressure in the, yes, thank you again. The lowest pressure in the aorta is going to be 80. So you can see that throughout the cardiac cycle, aortic pressure is higher than right ventricular pressure. So what will be my flow? The flow from the aorta to the right ventricle will be continuous. It's going to be continuous. So whether in systole, whether in diastole, the blood will flow into the right ventricle from the aorta because the aorta has higher pressure than the right ventricle throughout the cardiac cycle. So by this knowledge, right, you can just go straight. Do you have to read the vignette? I don't. I can go straight to my option, pick A and move on. Because once you see fistula and they're asking you flow, you start thinking, oh, this cardiovascular system, what is the pressure difference between, identify the chambers, between which chambers the fistula is, figure out the pressure gradients between them, and that will tell you the direction of flow, right, immediately. And you're done without even reading anything else, right, in this case. Okay? Any questions on this before we move on? All right. Let's see the next one. Okay. This is the next one. Okay, I think I have a question. Ella says isovolumetric concept. That is concept is different, right? It's talking about where the volume in the ventricle when the valves are closed. So isovolumetric means same volume. So there's a point in the cardiac cycle when the valves that open into, right, or leaves a chamber of the heart, right, they are all closed. If they are all closed, the chamber will not be able to receive blood or push blood out. So the volume of that chamber will remain constant, will remain the same, right, during that period. Okay, so that is isovolumetric concept. Okay, if you look at the cardiac cycle, and for instance, there's a point where the aortic valve will be closed. At the same time, the mitral valve will be closed as well. So during that period, the left ventricle is not receiving blood or pushing blood out, right? And the volume in the left ventricle will remain constant. So that is what isovolumetric, right, means. All right. Okay. So this is the next question. Let me relaunch the poll, and we have 90 seconds. We have 90 seconds, 120 seconds rather, and you can put your answers in the poll. Our poll is closing in 5, 4, 3, 2, and 1. Okay. Right, that's another good one. Good question. And here the popular answer is A. Decreased renal free water reabsorption. Decreased renal free water reabsorption. And E, increased urinary sodium excretion. Increased urinary sodium excretion. All right, let's see. Which of the following is the most likely effect of this medication? All right, I want to see if everybody has been following and making some adjustments, right, of their own. So I want you guys to advise me on my approach to this question. So we've read the question, right? I've read the question. Which of the following is the most likely effect of this medication? I have a bunch of options there. Where should I go next, guys? Should I go from the top and work my way down? Or should I go and read the second to the last sentence? What do you think? What should I do next? I've read the question, glance at the options. Where should I go next in my approach to this question? Should I go from the top and work my way down? Or should I go backwards? Okay, Oge says second to the last. Second to the last. Debola, Taza last. All right, excellent. Remember, we're trying to get into the examiner's head, right? Believe me, we want to get into the examiner's head. You gotta start thinking like the examiner. Which are the following is the most likely effect of these medication? If the examiner is saying these, these, where would the examiner likely mention the medication or give us clear about the medication? It's going to be just before the question. So I don't want to waste my time and read what I don't have to read. Sometimes it may not work sometimes, right? I may read the second to last statement and I can't figure it out. I may need to read more, that's fine. But you see that most cases, you don't actually, that might be enough, right? Will be enough in most cases. So the second to the last sentence says, is medical treatment is modified with the addition of a combination pill that inhibits neprilysin and blocks angiotensin 2 receptors. So the drug they're giving this patient is a combination pill. So the pill, which means there are two pills, one or two components rather in the pill, in one pill. So one of the components of the pill inhibits neprilysin, and the second one blocks angiotensin 2 receptors, right? Remember that pharmacology is what? Using medications to alter normal physiology. Pharmacology means using medications to alter normal physiology. So we need to go back a little bit and ask ourselves, what does neprilysin do normally? Who remembers? What's the function of neprilysin? What is the function of neprilysin? Neprilysin does what normally?
I think it inhibits AMP and BMP.
Right. Neprilysin breaks down, yes. So it takes BMP, BMP, AMP, neprilysin degrades. Neprilysin degrades AMP and BMP, right? It degrades them or neutralizes them. That's what neprilysin does. And it's also what has an effect on angiotensin 2 as well, right? It also degrades angiotensin 2 as well, right? So this drug, if I block neprilysin, we block it here. What happens to BMP, AMP? Their levels go up. And AT22 will go up, right? If I'm blocking neprilysin, BMP will go up, angiotensin 2 will also go up. But then the second component of this pill blocks AT2 receptor. So although AT2 will go up, but you're not going to see the effect of AT2, right? Because the receptor has been blocked. So our focus will be what? On BMP and AMP. So what will BMP and AMP do to free water? What do you think? What's the effect of BMP and AMP on free water? Does it normally reabsorb free water? Does it normally excrete free water? What is the effect of BMP and AMP on free water? Oge says natriuresis. So natriuresis means what? What is being excreted by BMP and AMP? They excrete natri. Natri is sodium, right? So sodium So this is where you have to be careful. You have to be technical, right? And specific. BMP and AMP do not have direct effect on free water. They can get rid of free water, yes, but they do that indirectly. They do that by getting rid of sodium. Okay, so BMP, AMP primarily target sodium. They block the effect of aldosterone, right? So they are going to increase sodium excretion, and then water will follow sodium. So that is why A is not the best answer. So if you're asking yourself, what effect does AMP, BMP have on free water? They don't have any direct effect on free water. Their effect is mostly on directly on sodium, then secondarily on free water. That's why although A is a close answer to E is still better than A because E is more accurate. AMP, BMP increase urinary sodium excretion, and secondarily, right, water will follow sodium. So the water AMP, BMP excrete is not a free water, right? It is a water with sodium, not free water. It is ADP, antidiuretic hormone, or ADH, that will what? Affect or has an effect on free water. ADH has an effect on free water, but AMP, BMP, aldosterone, they don't have effect on free water. They manipulate sodium, which will secondarily affect, right, water. Okay, so that's why E here is the best answer, although A will be the best wrong answer, right? It's closest to E, but it's not accurate, right? Okay, it's not accurate. Another thing I can do with this kind of question, so you can get a question in your exam where you have no idea what the drug does. So like we see here, they told us about injection of neprilysin. Unless I remember what neprilysin does, I'll probably miss this question, right? But since the second component also blocks angiotensin 2, I think I should be able to use that to still make the best guess, which will still be E. Because if I'm blocking, if I remember angiotensin 2 function, and I know that angiotensin 2 stimulates aldosterone, aldosterone will increase sodium reabsorption, I can still get this question correctly if I remember angiotensin 2, right? If I don't remember neprilysin, I'll still arrive at the same, right, answer, right? Another thing you can do is that if you get a question where you have no idea what the drug does at all, the next thing I can do is that the next thing I can do is that I can look at what the patient has, right? I can look at the condition the patient has. So for instance, I look at this, I have no idea what the drug does. Ask yourself what is being treated. Okay. So if I don't know what the drug does and I want to figure out what is being treated, I find out the patient has heart failure, right? That is what is being treated. You cannot look at the options and figure out what option will benefit a patient with heart failure. And here, I can use this principle to rule out, right? So for B, I want to increase venous compliance, not decrease it. I want the veins to hold blood so that less blood returns to the heart and there will be less congestion. So B will not benefit heart failure patients. Increasing contractility might benefit heart failure patients. So we're going to keep that. Increasing peripheral arterial resistance will not benefit, right, heart failure patients. Yeah, so I'm lucky here that I'm able to narrow down to 3, but I still need more information to pick the right answer. So sometimes this can help you by knowing what condition you are treating. You can use it to narrow down your options to what would benefit that condition, right? If I'm giving medication, but then maybe it might make it easier to pick an answer right after that. So that's just going to be another strategy that I can use. Sometimes you do this strategy and you only have one option remaining, and you can pick that and you move on, okay? In case you don't remember what the medication, right, does. All right, let's go on. Very good. This has a sound, which I don't think we're going to be able to hear. But let me see. Can you hear the media that I'm playing? Can you hear the media? No.
I could hear it initially, but I don't know if maybe try it again. No, I don't think so.
Okay, that's fine. Let's move on. All right, let's move on to this question instead. So I will share the poll for this one. And yeah. 30 seconds. So it's closing in 5, 4, 3, 2, 1. Okay, thank you. Most popular answer here is option B for this question. I'm actually interested in hearing why B. If somebody that chose B doesn't mind telling us why, that would be very interesting. I want to understand how you're thinking about this question. I want to understand the thought process for this question.
So I chose B because
Mhm.
I don't actually remember what the Milranon did, but during using the last step that we did in the
Okay.
last question, I figured
Okay.
that this person is having some kind of heart failure. So what
Uh-huh.
kind of medication would I want to give someone that has having have heart failure? And I'll be worried about like arrhythmia with someone with heart failure. So that's why I chose like anti-arrhythmic action for B.
Yeah. Okay. Amiodarone is an antiarrhythmic, right? Milrinone is different. Yeah. But I did like that approach of, okay, if the patient has heart failure, what will the patient benefit from? Of course, a drug that can decrease arrhythmia will be beneficial. So we're gonna keep option B. So I want to use that approach to kind of narrow down my options. Which other option what other option do you think will benefit a patient with heart failure besides B? So I ruled out A already. But which other option do you think will benefit a patient with arrhythmia, with heart failure? So we're assuming that we don't know what this drug is, right? In an exam, which is possible. So let's see if we can still find our way around, right? The correct answer. So we're keeping B because antiarrhythmic will be beneficial in heart failure. I agree. Is there any other option you think will be beneficial in patient with heart failure?
I think I want to cause vasodilation to reduce the preload.
You want to cross it, you want to
Like,
dilate,
like
right?
I'll give a medication that causes vasodilation
Okay.
and then
All right.
reduce preload to the heart.
Okay, to decrease congestion, right? Okay, so we are keeping F. Okay, right. So we're keeping B, we're keeping F. Um, E, I will rule out. I don't want to increase pressure in the right heart. That will be more congestion. I don't want to decrease. I want to increase renal perfusion because heart failure will already decrease renal perfusion. I actually want to improve that to help the patient. AV block will make things worse. I don't want a medication that will cause that. All right. So B or F can benefit a patient with heart failure. Excellent. So I still need to know what the drug does, right? I'm not know to two things, but I still need to know what the drug does, okay? To figure it out. So Mirinon is a phosphodiesterase, PDE inhibitor, phosphodiesterase inhibitor. And if it inhibits, so it can work on two locations. It can work on the heart, and it can work on the smooth muscles of the blood vessels, right? If we inhibit PDE, we're going to increase cyclic AMP. So PDE is a PDE3, I believe, is one of the enzymes that metabolizes CAMP, cyclic AMP, right, in the heart and the smooth muscles. So milrinone will inhibit that. When it inhibits it, it is going to increase cyclic AMP, right, in the heart, and also increase cyclic AMP in the muscles. If I increase cyclic AMP in the heart and I activate protein kinase A, it is just like when you stimulate beta-1 receptor in the heart, there should be increased what contractility, right? So milrinone is a positive inotropic drug, right, in the heart because of the effect, which will be beneficial in patients with heart failure, right? Push blood out of the heart, but it does not have antiarrhythmic effect, okay, on the heart. It's an inotropic agent, it increases contractility. But on the smooth muscles of the blood vessels, if I increase CAMP, which will mimic stimulating beta-2 receptor on the smooth muscles of the blood vessels, so this will actually cause vasodilation, right? It's going to relax the smooth muscles, and the smooth muscles will be dilated, right? So this will cause vasodilation. If I dilate the veins, I will decrease venous return. If I dilate the arteries, I will decrease TPR, which will both be beneficial, right, in patients with heart failure as well. All right, so F here will be the best answer for Marina. Although I like how we narrow down the options, but F will be the best because Marinon is a PDE inhibitor. Okay. Ella, what don't you get? Tell me. You can put what you don't get in the chat so that I can target that specifically. All right. Okay, so the question is, what is the response? What is the most likely response to this therapy? So the examiner is asking you, what effect will this therapy have on this patient? What therapy is the examiner talking about? Milrinone is the therapy. If I know what milrinone does, I can figure out, I can just go straight and work it out, right? So milrinone blocks phosphodiesterase enzyme, an enzyme that breaks down cyclic AMP. If you block that enzyme in the heart, cyclic AMP will be high, and that will stimulate contractility, increase contractility, right? If you block cyclic AMP in the smooth muscles, it will relax the smooth muscles, and they become dilated, and the vessels become dilated. If the veins are dilated, they hold more blood, less blood returns to the heart. If less blood returns to the heart, there will be less congestion in patient with heart failure. And also, if you relax the smooth muscles in the arteries, that will decrease total peripheral resistance. So less resistance to ejection of blood. Also, that will be helpful to increase cardiac output, right, in patients with heart failure. Yeah. So that is why vasodilation is the best answer, because this drug is not an antiarrhythmic drug. It's an inotropic drug. It increases contractility. So B is not correct. Okay. If you increase contractility, you are pushing blood out of the heart. Patient with heart failure, they are congested. The heart is congested, the lungs are congested. So increase contractility and push blood out of the heart. That is not antiarrhythmic effect, right? It is an inotropic effect. All right, let's try this one next. Seconds. Hold close in 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. All right, this is an interesting question as well. Very interesting. So the results are split between option C and D, right? Two persons went with C, right ventricular infarction, and one person went with option D, septic shock. So we have anaphylactic shock, GI bleeding, right ventricular infarction, septic shock, and severe aortic stenosis, right, in the options. So we want to figure out what the patient currently has. So let's see what we have. 63-year-old man brought to the ED due to an episode of syncope. So patient lost consciousness. And the patient was recently discharged back to a nursing home after being hospitalized for a UTI. I want to mention something very clearly, right? One of the least important information in your vignette are past histories, right? They are some of the most distracting, right? Information, least important. So be careful making decisions with that, because I am sure some of you will see these and start thinking, oh, this could be septic shock, right? No, not everybody that have recent hospitalization with UTI will have septic shock. Does that make sense? So you have to be careful. Take information like this with a grain of salt. In fact, ignore them if you can and just focus on objective findings, right? So the objective findings and HPI, right? Those are the most important information in any vignette. Any other information, they are not as important. You can skip them if you have to initially, so that they don't distract you, because that's what they'll put the distractions, right? So that's important. And then some of us might see coronary artery disease history. And of course, that may be important clue that, okay, patient could also be having another MI, but not everybody with coronary artery disease also has MI, right? Later on in life. So you have to be careful. Make sure you prioritize your objective findings over subjective, right? And past information. So let's see the objective findings. There's syncope, and then if we jump to the blood pressure, we say that the patient is hypotensive, pulse is elevated, tachycardic, right? So they did an invasive hemodynamic monitoring, and it revealed that what the right atrial pressure is 17, which is high. The pressure on the right side of the heart is elevated, but the pulmonary capillary wedge pressure is slightly low, right? So that is important. So we have to use so those are the important information we have. The most important information we have there are the hemodynamic monitoring, right? We have to use the pressure in those chambers to kind of figure out what is going on in the patients, right? So if we take them one by one, right? If right atrial pressure is high, it could mean a lot of things, right? But one of the things is going to be first of all, the right heart is not working properly, right? There's right heart failure. If there's right heart failure, the right heart will be congested, right? And the pressure in the right heart will be elevated. So I have to start thinking in that direction. Secondly, it could mean that there's an obstruction. There's an obstruction between the right heart and the pulmonary artery, obstruction between the right heart and the left heart. So that is why the right atrial pressure is high. Okay, so I also have to think about that. It could be a valvular disease like tricuspid stenosis, tricuspid regurg, right? Even pulmonic regurg and stenosis. Those things can cause the pressure on the right heart, right, to be elevated. So I'll be thinking in that direction, right, when I see elevated right atrial pressure. Okay, and what side of the heart does pulmonary capillary wedge pressure measure? The pressure in the pulmonary capillaries, it gives us information about which side of the heart, right or left. The PCWP gives us information about which side of the heart. Okay, the left side, excellent. Left atrium, which corresponds to the left heart, right? So if there's any left-sided pathology on the option, I can read it out. Because the pressure is the PCWP is normal, even slightly low. So I can rule out left-sided pathologies. I know it's not a left heart failure, right? I can rule it out if I see it's an option. I will think, oh, this is not mitral stenosis or mitral regurg. It's not aortic stenosis or aortic regurg, right? So it's not an obstruction in the aorta somewhere, transmitting pressure backwards. So I can rule out left-sided pathologies and I'll focus on what right? Atrial pressure, right? Right-sided pathologies or something else. So let's look at the options we have. So anaphylactic shock. What will happen to right atrial pressure in anaphylactic shock? It's going to be low because of the peripheral vasodilation. So there'll be less blood. If the peripheral vessels are dilated, there's going to be less blood returning to the heart. So right atrial pressure should be low, right, in anaphylactic shock, and patient doesn't have any other feature to support that. In GI bleed, there'll be less blood returning to the right heart, so the right atrial pressure should be low as well, right? C is a right heart pathology. I'm going to keep that. Septic shock, there's also going to be low pressure on the right side of the heart because of peripheral vasodilation. And then aortic stenosis is left-sided pathology, but we know that the left side is fine because PCWP is not elevated. So that leaves us by default with C, right ventricular infarction. Okay, leading to right heart failure, most likely. Right ventricular infarction. So C will be the best. So the second part of the question, this is the second part of the question. So the first part says patient is in cardiogenic shock due to right ventricular infarction. So this is the second part of the question, testing another component. So try this as well, and let's use the poll. There we go. 30 seconds remaining. Even in 5, 4, 3, 2, and 1. Okay. So very good responses. Most popular answer here is option E, splenic flexure, followed by C, right? Hepatic, right? Flexure. What do you think this question is testing? Who can type in the chat the concept or tell us the concept that has been tested by this question? What concept is this question testing us on? It's important to understand concept. Blood supply, and so watershed, excellent. Watershed, right? It's not just blood supply, but watershed, right? That is the concept. Watershed areas, areas that are poorly perfused because they are the ends, right? Or areas that are areas that are prone to ischemic necrosis because they are located at the ends of two terminal, right? Blood supply or blood vessels, okay? So, and the clue the examiner gave us, number one, we already know from the vignette that this patient is in shock. That is hypotension. So of course, every organ in the body will be hypoperfused. They're not going to get blood flow. All the blood vessels in the body will not get enough blood flow. Okay. So, and then the patient died. After dying, they told us that on autopsy, there's bilateral hippocampal necrosis. So you have to know the watershed areas, right? So in the brain, hippocampus is a watershed area, right? In the brain, the hippocampus, the watershed area. It is between what? The junction of the middle cerebral artery and the anterior, right? Cerebral artery. So imagine if there's a land between two holes for water hoses. If the pressure in those water hoses go down, right? That land at the end will be driest. It's going to be the driest, right? Of any part of the vegetation of the land. So that's the same thing with the body. If you have a vessel or an organ or a tissue that's located at the end of two terminal vessels, if the pressure in those vessels drop or the blood flow in those vessels drop, that tissue will be at risk because it will not have any blood supply, right? Since it's at the terminal end of two, right? Vessels. So this hippocampus is one of those watershed area. So the question is asking us, what other watershed area do we have in the colon? And that is going to be the splenic flexure, right? So the splenic flexure will be a watershed area in the colon located between the SMA and the IMA, right? It's located between the superior mesenteric artery and the inferior mesenteric artery branches at the terminal ends of those vessels. So if there's a diffuse hypotension, that area will be most susceptible, right, to ischemic necrosis in the colon. All right. Here will be the best. Hepatic flexure is on the right side, right? And it is well supplied by the SMA. Right? Remember that the SMA also supplied the lateral two-thirds of the transverse colon, right? So the hepatic flexure is well supplied, but the splenic flexure on the other hand, it's located at the end of the SMA and the beginning of the IMA, right? So it will be a watershed area and most likely to die in this case. So it will be the best. Very good. Let's try this one. 10 seconds to go. Attempt the questions. Make sure you pick an answer or have an answer written down so that way you can always compare, right, with what we come up with and our approach. And you can compare with yours and make appropriate or adequate changes where you need to. So the poll is going to close in 5, 4, 3, 2, 1. Okay. And another thing I want to encourage you is to force yourself to pick an answer, right? And you remember that in the exam, first of all, some people don't pick answers because they are not sure, right? Oh, I'm not sure. And they'll rather not pick anything. It's now, you have to get into the habit of picking something. Don't leave a question blank, right? If you leave a question blank, you are most likely to get 0. I always tell people, even if you have the mind to come back to the question, pick an option, mark it, and move on. In case you get to the end and you don't have time to come back, that's, I call it educated guess. Make it the best educated guess. And truly, that's why you say that your questions never ask you, for instance, which of the following hemodynamic changes are present in this patient? They only use words like most likely, because what are we doing? We are making an educated guess, most likely. It means that sometimes you get a question where multiple answers can be correct, but right now, what is the best answer? What is the most likely right answer? So never leave questions blank. Don't be afraid to pick something if you are not sure. Just try to narrow down, right, as best as you can, okay? And pick it, mark the question, move on, come back later if you have time and review it, right? But don't leave questions blank, okay? So for this one, we have which of the following hemodynamic changes are most likely present in this patient? And the examiner wants us to decide what would be the pulmonary capillary wedge pressure, if it's decreased or increased, what will be the central venous pressure, what will be the coronary perfusion pressure, right? We saw PCWP in the previous question. So you should know, we know what PCWP means. And I don't just want you to know the definition, right? Understand what it represents. Understand what factors can affect PCWP, what factors can increase it or decrease it, right? For CVP, what does CVP mean? What does it suggest? It's an index of what? CVP is an index of what in the cardiovascular system? Central venous pressure is an index of what? Right atrial pressure. Okay, so central venous pressure is an index of right atrial pressure. It's also an index of venous pressure, the pressure in the vein, right? If the heart is not beating, right? So it's an index of the right heart, pressure in the right heart, which is transmitted into the venous system, right? And it's also an index of the pressure in the veins, assuming the heart is not beating, right? What will be the pressure in the veins, right? That's also what CVP represents. Can you give me an example of something that can affect CVP? An example of one thing that can increase CVP and something that can decrease CVP. An example of what can increase central venous pressure and an example of something that can decrease central venous pressure. An example of what can affect CVP, increase it, and what can decrease it. Pulmonary arterial hypertension can increase CVP, right? So if pulmonary artery pressure is high, it's going to be transmitted to the right side of the heart and to be transmitted to the venous system, right? So that can increase CVP. I agree. What can decrease CVP? What can decrease CVP? CVP can be decreased by hemorrhage, for instance, right? Right, yes. So venous dilation, right? Venous dilation can decrease CVP. If the veins are dilated, the pressure in there will drop, right? And also things like hemorrhage, things that decrease blood volume. Okay, excellent. So that's CVP. And then coronary perfusion pressure is the pressure that perfuses the coronary artery, right? Which is indirectly testing us on, okay, let me ask you guys this. Coronary perfusion pressure. How will I calculate for coronary perfusion pressure? What will be the mathematical expression? for coronary perfusion pressure. It will be the pressure difference between which two vessels. Coronary perfusion pressure will be the pressure difference between which two vessels. Coronary perfusion pressure will be the pressure difference between which two vessels. It will be the pressure difference between the aorta, because the coronary artery is connected to the aorta, right? And it is filled during diastole. So we could say that it will be the difference between the diastolic blood pressure in the aorta and the coronary, right? Arterial pressure. This would be the perfusion pressure. So which means that if the diastolic blood pressure in the aorta is higher than the coronary artery pressure, the coronary artery will be filled, right, with blood. It's going to be perfused. If the diastolic blood pressure in the aorta is lower than the coronary arterial pressure, then the coronary artery will not be perfused. So the reason I'm putting this here is for you to understand what can affect this coronary perfusion pressure. It will be anything that could affect, right, aortic pressure, right? Aortic pressure, actually the diastolic blood pressure, right, in the aorta, that can affect this perfusion pressure, right? Or anything that can affect the coronary arterial pressure. Maybe the coronary artery gets compressed, for instance, by the muscles, myocardium, that can also affect, right, the perfusion pressure, okay? So perfusion pressure for any organ is the pressure between typically between the aorta, the difference between the pressure in the aorta and the pressure in the vessels, right, in that organ. All right. Okay, so let's dive in since we have a better idea of what this indices means. So we have a patient that is 55. So in this vignette, I want to focus on what is most important, right? If I'm going from the top, I want to focus on what is most important. Patient is 55. Patient has suddenly collapsed at home 20 minutes ago, right? And the next sentence is relevant, right, to the HPI. It's relevant to the chief complaint. The patient reported chest pain and then collapsed while trying to sit down. So I can skip medical history. For now, let's assume that is not relevant to us, right? So it's just jargons. So let's keep it for now and go to the objective finding. And we have temperature is normal, pressure is low, right? Hypotension, patient is tachycardic, respirations 22. It's also high. On examination, the patient is in marked respiratory distress. Bilateral crackles are present, right? And S3 is audible, and ECG reveals ST segment elevation in leads V2 through V6. What is the most likely diagnosis in this patient? What is the most likely diagnosis in this patient? What is the most likely diagnosis in this patient? What is the most likely diagnosis in this patient? This patient is in cardiogenic shock. Okay, cardiogenic shock. What is the cause of the cardiogenic shock? What is causing cardiogenic shock in this patient? What is the cause of cardiogenic shock in this patient? Okay, Rashid said heart failure as well. I agree. Patient is in heart failure. The heart failure is causing shock. It's cardiogenic shock. What is the cause of the shock or heart failure? What is causing the systolic dysfunction? The patient has what? Had or is having a MI, right? Myocardial infarction. So it's STEMI. There's ST elevation in leads V2, right, to V6, right? So patient had an MI, myocardial infarction, and now the heart is failing, okay? The heart is failing. Excellent. Which side of the heart is failing and why? Is this patient experiencing right heart failure, left heart failure, or both? And why? You have to support your answer. Which side of the heart is failing in this patient? Left heart. Why left heart failure? What here is specific for left heart failure? What here suggests left heart failure? Crackles, right? Crackles. Okay, Adebola says both. Okay. Itiza says because it collapsed suddenly. All right. So remember, loss of consciousness could be from anything. Syncope could be from, can happen from, can be due to right heart and left heart failure, right? Can be due to both. Okay. So it's not specific for one side, right? But in this case, right, what's specific for right heart failure, for left heart failure is going to be the crackles. You have crackles in the lungs. If the left heart fails, fluid will back up into the lungs, right? Fluid is going to back up into the lungs, right? So that is specific. That is more suggestive, right, for left heart failure. And also we have S3. S3 means dilated ventricles, dilated chambers, right? So also left heart, right, failure. And but I think this is likely going to be both because of the severity. And if the left heart fails, it will eventually lead to what? Right heart failure, right? Although we don't have anything specific here for right heart, but I think the pressure will back up, right, to the right heart as well, to some extent. So let's go to our options now and narrow down what our answer would be. So what will be PCWP in this patient? What is going to be the PCWP in this patient? What will be the PCWP in this patient? Or be PCWP in this patient? Will it be decreased or increased in a patient with heart failure, left heart failure? The PCWP is going to be high, right? Because of congestion, right? The left heart will be congested. The pressure in there will be increased, right? Now, when you get questions like this, right? Questions that give you multiple indices for you to determine which one, arrow up, arrow down, decrease, decrease. Always start with the one you know or you are sure of. That's how you approach this, right? So because I'm starting with the first one doesn't mean that's what you're going to do. If you're not sure about PCWP, if you're sure about CVP in patient with heart failure, start with that. If you're sure what the coronary perfusion pressure will be in patient with heart failure, start with that, right? But so you start, the principle here, the strategy here for questions like this is to start with the index you are sure of, right? So, and that will help you narrow it down, right? So if I'm sure of the first one, I start with that, and I know it to be high in patient with left heart failure. So I can rule out what? I can rule out the options A and B, right? Based on the first one alone. Then next one says CVP. What will be the CVP in this patient? What will CVP most likely be in this patient? Will it be decreased or increased? Central venous pressure. Patient has heart failure. What will be the central venous pressure in this patient? CVP is going to be high as well. If the left heart fails, the pressure will back up all the way to the right heart as well, and CVP will be high. Excellent. So CVP is going to be high as well. So I rule out C. I'm left with D and E, right? What about coronary perfusion pressure? Coronary perfusion pressure. Will that be increased or decreased? Coronary perfusion pressure is going to be decreased. Excellent, Rashid. In fact, the perfusion pressure to all the organs in the body will be decreased because why? The blood pressure is low. So the pressure in the aorta is low, which means the pressure that we're pushing blood to the organs will be low as well. So that rules out E, and we are left with D as the best answer in this case. All right. So D here will be the best. So expect PCWP to be high, CVP to be high, and coronary perfusion pressure to be decreased because of low pressure, right? In the order. Yeah. So for questions where you have several indices like this, where you have to choose from or determine, always start with the one you are sure of. Okay. Central coronary perfusion pressure. So perfusion pressure is the pressure that pushes blood to organs, right? Perfusion pressure will be the pressure that pushes blood to organ. And what will be the pressure that will push blood to organ? It is usually the pressure in the aorta, aortic pressure, minus the pressure in the organ, right? The vessels in the organ. So if I want to know, if I want to estimate, right, calculate the coronary perfusion pressure, It's going to be the aortic pressure, typically the diastolic pressure in the aorta, right? Because coronary artery fills during diastole. The diastolic pressure in the aorta minus the pressure in the coronary artery. That will give me the perfusion pressure of the coronary, right, vessels. So normally in a healthy patient where the diastolic pressure is 80, right? The diastolic pressure is 80. You expect what? You expect the perfusion, assuming the pressure in the coronary artery, let's assume it's 20, right? What's the perfusion pressure? It would be roughly 60. But in this patient, look at the diastolic pressure is 50. So 50, assuming the coronary pressure is still 20, you can see that it has dropped to 30. So there will be less blood flow to the heart because the pressure in the aorta is low and there will be less blood being pushed, right, to the coronary vessels. And this also affects not just the heart, it's going to affect all the organs in the body, okay? All the organs in the body. Yeah, for Itazer says that's how we should do questions that, right? So I'm saying questions that have multiple indices, right? Where you are giving question like this, what changes do you expect? And you're giving PCWP, CVP, coronary perfusion, maybe you're giving diastolic blood pressure, systolic blood pressure, or some other in the multiple indices. And you have to determine which one is low, high, decrease, arrow up, arrow down. Always start with the index you are sure of. So once I know that this is heart failure, right, from the presentation, from these three now, if let's, I may not remember, I may not know what this is, right? I may not be sure about this, but if I know PCWP for sure, I'll start with that and use that to narrow down, right? If I know CVP, I'll start with that or I'll use that to narrow down. So the point is, you have multiple indices. By the time you complete the ones you know or finish with the ones you know, you see that the last one or the ones you don't know will just align, right, in the option, and you can just pick your answer easily. All right. Yeah. So that's be your strategy for questions like this. Start with what you are sure of, and then you build on that with the rest. Okay. So let's do this one next. Very seconds. All right, guys. Poll is closed. So also an interesting one. Here we have, okay, double exchanging option is C. Okay, that's fine. So this is a very interesting question. It's testing one of the most important and high yield topic you will encounter, right, on your exam, and also in clinical medicine, in medicine when you start practicing. So this is testing coronary artery disease, right? And the question is asking us what we're going to see on cardiac catheterization in this patient. What we're going to see on cardiac catheterization, and it's describing different pathologies in the coronary artery. So we have option A says atheromatous plaque obstructing 50% of the coronary artery lumen and no thrombus. Atherosclerotic plaque obstructing 80% of the coronary artery lumen without any thrombus. Ruptured plaque with fully obstructive thrombus. Significant coronary artery vasospasm causing flow obstruction and ulcerated atheromatous plaque with partially obstructive thrombus. Okay, so I want us to attach a diagnosis to each option. So I want to approach this differently. Instead of reading the vignettes first and coming back to the question and the option, tell me about option A. Who can tell us what option A will present? What will be the diagnosis for a patient with option A? What will be the diagnosis for a patient with option A? If I check coronary artery catheterization and I see atherosclerotic plaque obstructing 50%, but there's no thrombus, what will be my diagnosis? Oge says stable angina. Etaza says angina. So if A is angina, what is B? If A is stable angina, what will be the diagnosis for option B? What do you think? If A is stable angina, what is going to be the diagnosis for option B? So option B will be unstable angina. So here's what I want you to think about. There's something we call critical stenosis in the coronary artery. Critical stenosis is the minimum narrowing in the coronary artery before patient develops signs and symptoms, right? The minimum occlusion in the coronary artery before patient becomes symptomatic. You see, option A is going to lead to asymptomatic coronary artery disease. It will be a patient A, 50% stenosis is not critical stenosis. Right, Rashid, you need 70% minimum. So a patient that has less than 70% stenosis in the coronary artery will be asymptomatic. They won't know. If the patient has this kind of stenosis in multiple arteries, later in life, they may develop heart failure, because of that chronic ischemia. But you see, if it's just one artery, you're not going to see any symptoms. Patient will be asymptomatic. They don't have any symptoms at all. So A will be a patient with asymptomatic coronary artery disease, somebody that will never present to you, to the hospital. Okay, so A is asymptomatic. So B will now be what? Stable angina. That's what B will be. B is going to be stable angina. So stable angina, there's a stable plaque. The plaque has not ruptured, but it's causing at least 70% stenosis. This is when patients start becoming symptomatic with exertion, right? And it will get better with rest, right? So B will be stable angina. Now, what about C? What will be diagnosis for C? What will be the diagnosis for C? What is going to be the diagnosis for C? C is going to be MI. Which MI? N-STEMI or STEMI? Is this going to be ST elevation MI or non-ST MI? It's going to be STEMI. It is going to be STEMI, right? So when the plaque ruptures, and there's a superimposed thrombus. So whenever the plaque ruptures, we're going to expose, right, the core. We're going to expose the core of the plaque, and then there's going to be superimposed platelet thrombus, okay, on that plaque. And that will lead to what? 100%. It's going to fully occlude. And that's what's STEM, because that will lead to what? Total infarction of the wall. right? It's going to lead to transmural infarction. The full thickness of the wall of the myocardium will undergo infarction since you are completely cutting off the blood supply rather to that muscle. So this will lead to STEMI, ST elevation MI, right? What about D? D, what will be diagnosis for option D? What will be diagnosis for option D? Option D is going to be Prince metal angina, right? Option D is going to Prince metal or vasospastic angina, right? Vasospastic angina. Very good. And then E will be what? Option E will be what? Ulcerated plaque as well, but this is a partial occlusion, partially obstructive thrombus. There's an ulcerated plaque causing partial, it's not 100% yet. Option E will be what? It's going to be unstable angina or what? Unstable angina or what? Unstable angina or what will be E? Unstable angina or it could be N-STEMI. Yes, unstable angina or N-STEMI. How will I differentiate them from each other clinically? Both of them will have the same lesion, except that N-STEMI is longer, like there'll be more vessels, multiple vessels involved, as well as the duration of the occlusion, right? Although it's partial occlusion, the duration will be longer, so there's already myocardial infarction. Unlike unstable angina, where you see the same lesion in the coronary artery, they'll have symptoms as well, but because the lesion is still early, doesn't progress to infarction yet, or it's a few vessels, not multiple vessels, so there's no infarction yet. So you usually differentiate them clinically by checking what cardiac enzymes, right? So in N-STEM, because there's already infarction, the cardiac enzymes will be elevated as well. In a stable angina, I will not see infarction yet since the occlusion is not, it has not progressed to infarction yet, right? So E could be unstable angina or N-STEM, right? So these are our differentials for these lesions, all right? So this is one of the ways you can generate differentials for a vignette. That's another technique I'm teaching you now, right? There's always a way to the correct answer. So this is one way. Before I go through a question, I'm not sure what the answer is, I can look at the options and use the options to generate a differential diagnosis, right? And then I'll now go back to the vignette and pick an answer that is similar to what I'm thinking, all right? So what information do we have here? We're given ECG, and the ECG shows what? The patient has ST segment elevation in leads 1, AVL, V1 to V4 with some Q wave developing, right? So this patient has STEMI, right? This patient has ST elevation MI. And because of this, we go to our differentials. Our best answer is going to be C, because C represents STEMI. All right, there will be 100% occlusion of the coronary artery. Is there any question on this? All right. This will be our final question. So I want to open the floor for any questions from today's session that you have not asked. Anybody have any question from today's session, from the questions we went through that you have not asked? So Itaza, for you to go through explanations quickly, like I mentioned in the beginning, you time your review, right? So if I can go through timed blocks, I should be able to also time my review of the block, right? So it doesn't make sense to not time it. By timing your review, you can give yourself, you can minimize the amount of time you spend, right? On that review. So that way you can do more questions, right? For that day. So time your review, you can time it for 2 hours, 2 hours, 30 minutes. So that'll give you a sense of urgency that you don't have all day, and you can focus on only the important part, right, of the explanation. The goal of going through explanations is to compare your thought with the examiner's thoughts, right? That's why we go through explanations or review questions. Compare your thoughts with the examiner's thoughts. So when I go through explanation, I want to make sure that what the reason for choosing the answer or the reason for choosing the wrong option, you want to see what the examiner has to say, right? About that, or what the examiner has to say about the correct answer, and make sure your reasoning start aligning, right, with the examiner over time. All right. So you should time your review so that you don't spend too much time on it. The second tip is going to be prioritize. Prioritize your review. Prioritize the wrong questions. So if I go through a 40 question block, after doing a 40 question block and I want to review it, I will start with the wrong questions first, right? I will start with the wrong questions first. And then after reviewing the wrong questions, I will go through the questions I got right, but I marked or flagged, right? So I'll go through the questions I got right, but flagged, which means I have some queries or I have some doubt about them. So I want to clarify the queries. And then the questions I got correctly, I'll review last. And those ones, I don't have to spend a lot of time on them. Since I got them right, and I know why I got it right, I know why the wrong answers are wrong, I'm not going to waste a lot of time there. I can just confirm that my thoughts are in alignment with the examiner's explanation, and I'll move through those ones pretty quickly, right? So that way you are doing the questions that you got wrong, they're the ones that you need explanation on, you need clarity on, there's something you're missing. So you really want to go through them early, initially during the review process, and spend as much time on them as possible. But then you go through the ones you got right but flagged to clarify your doubt. And then you can quickly skip through, right? The ones you got correctly without wasting much time. And that's how you review, okay? So also if I set a 2 hour, if I set 2 hours or 2.5 hours for review, I would have completed the questions I have to review before the time goes off or the time ends. So if I set maybe 2.5 hours for my review, before that 2.5 hours ends, I would have completed the review of the wrong questions, completed the review of the right questions that I flagged. And even if the time goes off before I review the ones that I got right, it's still okay to move on, right? Because I got them right, I didn't flag them, I definitely know those concepts, I'm confident about them. Why would I want to spend extra time reviewing something I already know? You have to be efficient, right? So that is why I say prioritize your review. So those are the 2 tips I gave, right? For that, right? On that. Rashid says, incorrect is just to understand, you're comparing the examiner's explanation with your own thoughts, right? So that's going to be your goal, right? For incorrect. How do you know if you have reviewed a block properly and haven't? You may not know immediately, right? It's when you do questions more. So the best way to know if you really understood what's reviewed in a block is actually do more questions. So it's okay if you identify, right? So the best approach would be when I review a 40 question block and I see at the end of the review, I go through the breakdown of that block. I see the topics or systems that I missed the most. It is okay to do the next block on that topic instead of starting new random block, right? I can do, actually, if I really struggle with it, let's say most of the questions I fail in a block are on MI or coronary artery disease. That is telling you, okay, you have a problem there. Even after reviewing that block, the next set of questions should be on coronary artery disease. And so to quickly reinforce and see if you actually clarify the concept. So if that next block is way better, you did really well on coronary artery disease, it means that, well, you really understood what you just reviewed in the block, and then you can move on, right? But if the block is still bad, you review that block again properly, you understand, you think you understand, you do another next block on coronary artery disease again, and you still struggled, then it means that, well, you need another resource. You need maybe a review video, right, on coronary artery disease or a tutor, right, to put you through something that you're missing, all right? So the best way to know if I really understood what I review is to do a block on questions that I really struggled with in the block that I reviewed, right? And see if I improve. If I get better, then I've keyed it down, it's clear. If not, you may need to do a quick review video or talk to somebody that may be able to put you through, right? What you're missing, all right, there. How to actively watch videos for concepts and remember. Talk to yourself. There's so many ways. Flashcards, right? You can create flashcards. You can create notes. A lot of us create notes and we don't go back. You have to schedule review, right? Do scheduled reviews of your notes, right? Schedule review. Maybe every three days, you have to go through whole notes, right? And when you go through them, you're not passively reading them. You're using them as memory cues to remember what you have to read, right? You're using them as memory cues to remember what you've read about that concept. And you can also try to actively talk to yourself, discuss it with other people. I think those are the best ways to actively, right, learn concepts. You can also write them out, right? There are concepts that you've listened to it, you've read it. You can take a blank sheet of paper, write as much as you can remember and understand about the concept, connect it with other systems. That's another way, right, to actively, right, master things, all right? And yeah, those are the questions I'll treat for now. Any question I not treat in this class, please put it in the WhatsApp group, right? And I will treat it there, okay? Thank you so much for your patience. But before you go, guys, so this free tutorial, right, that we have ongoing will end next week, right? Our last session will be next week, Saturday. And we're also going to dissolve the WhatsApp group, right, that we have. But the objective of this free tutorial is just to give you a taste of what we offer, right, as Essential Tutors, what our tutors have to offer, the kind of programs we have. And I hope that some of us have really found this really beneficial. And if you found it beneficial and you don't want this to end, we are going to continue, right, what we're doing now with a paid community, right? So with a paid community. So we want to set up the same thing that we're doing now, but we want to set it up for 3 months, right? For 12 to 13 weeks, where during the week we are putting topics. We can set up a schedule, which you can also use, right, for your own study. And during the week, we're putting up topics on different, on the group, and we're putting questions daily and trying to engage you and get you to review, right, topics and give tips to study and things like that. And then on weekends, we're going to be holding a problem-based tutorial session like we've done last week and today. And also we're going to have one of those weekends will be Ask Me Anything, right? Weekend where you can ask questions related to your study, related to what you're struggling with, and you get that group support, right? So that you don't go through this process alone, okay? So currently the program is supposed to be 150 USD, right? For the whole 3 months, but we are giving a early bird price for 120 USD, right? So anybody that is interested in the program and they register, right, for the program, for the paid program between now and March 1st, that's next week, Saturday, they get like a $30 off, right, the original price. And but it's going to be for 3 months. We don't want to keep people too long in the program. We want you to have a goal. So whether you're starting with your preparation or you are somewhere along the preparation and you are close to writing the exam, by having a 3-month window where you can always evaluate and go like a rigorous, basically, study guide, that will help you get the exam out of the way as soon as possible. And you don't have to do it alone. You have support of your peers, support of experienced tutors, right, in the group. So if you're interested, reach out to us and we're gonna send you the links, right, for appropriate registration. And we extend, you basically just continue, right, what we've been doing with us for another 12 weeks, all right? So that is what we have to offer. And then we also have other sessions like one-on-one tutorials. So what we are doing here in the group, if you feel like you benefit more with one-on-one tutorials, or your exam period is shorter, is closer. So you are taking your exam in 3 weeks, 1 month, and instead of waiting for the 12 weeks, you can reach out to us and our tutor will be happy to work with you one-on-one and basically reciprocate what we are doing in class here as a group with only you and help you get ready for your exam, right, faster. And also if you enjoy our tutors explanations, right, of concept and information and how it gives you strategy and everything. We also have self-paced courses. So our lead tutor has like 5 years plus of experience doing this, and he has recorded lecture videos explaining concept, explaining difficult concept, giving tips and strategies for different questions. So we have self-paced courses for medicine, for basic clinical sciences, for biochemistry, for obstetrics and gynecology. And if that's what you want access to boost your foundational knowledge, to boost your knowledge and your concept, we also have that as well, right, to offer. You can always reach out to us and we'll tell you more, right, about those packages. So in the meantime, though, thanks so much for your patience and coming this afternoon. I will see you guys next week, Saturday. Next week, Saturday will be 1 hour of Ask Me Anything, right, session. So come with all your questions or concerns about your exam prep, and we'll trash them out together with practical solutions. And also we can go through some questions as well with any spare time we have. Thank you so much once again. Have a wonderful day. Bye.